Hello and welcome to our presentation on incorporation of pre-exposure prophylaxis, or PrEP, for HIV prevention into HIV screening programs. I'm Dr. Suzanne Doblecki-Lewis, and I'm representing the Expanded Testing Initiative, the University of Miami and UHealth, which is supported by the Florida Department of Health as well as the South Florida Southeast AETC program. This program is designed for providers and administrators at health centers, and will go over several topics related to HIV testing and PrEP. First, we'll talk about what PrEP is and who it is for, how and where PrEP is delivered, what are the models for combining PrEP with HIV screening in practice, and some resources that are available. We'll begin by exploring some of the epidemiology of HIV infection. In this heat map of the United States, you can see that the dark red areas, representing areas with higher HIV prevalence, are overrepresented in the southeastern United States, and that Florida is particularly heavily impacted by HIV infection. When we look at the data for Florida and more locally at Miami-Dade County, you can see that HIV case rate each year has dropped since 1998 throughout Florida as well as in Miami-Dade, with the advent of effective testing, prevention programs, and engagement of people who are living with HIV in care, including antiretroviral therapy. However, you'll also see that there's a leveling out at quite a high rate of infections, both in Miami-Dade County and in the state of Florida, and that we haven't realized much additional gain in case reduction over the last 8 years. Realizing that the case rate for new HIV infections remains unacceptably high, we're looking for new solutions and new ways to prevent infections. PrEP is one of these ways. So what is PrEP? PrEP stands for pre-exposure prophylaxis. Basically, it's when people who are HIV negative are taking medication before a potential exposure to HIV in order to prevent becoming infected with HIV. PrEP involves taking medication to prevent HIV. There are 2 other times when we also use antiretroviral medications to prevent HIV. I'm going to step through what these 3 times are now so that we can distinguish PrEP from the other interventions using medications. As I already mentioned, PrEP is when medication is taken prior to an anticipated exposure in order to have levels of medication in the body at the time of exposure that are protective against becoming infected with the virus. PrEP, therefore, is usually taken every day and is important to maintain over time. People can start or stop PrEP as needed, but usually will plan to take it for at least 3 months when they're initiating it, and make a decision at a later time if they feel they no longer need it. PEP, in contrast, is post-exposure prophylaxis. This is when someone has an exposure, realizes after the exposure that it may have occurred, and seeks medication in order to prevent an infection from taking hold. PEP is different because it needs to be initiated within 72 hours of an exposure and lasts for a defined period of time, 28 days. So for PEP, a person may be exposed, say with a sexual encounter, and then seek care, and will take 3 medications for 28 days, and then get a retest at the end of that period of time. So PEP is for a defined period of time and needs to be started urgently. ART, or antiretroviral therapy, for someone who's living with HIV is also a very effective way to prevent transmission to a partner. This means that someone who's taking medication for their own health in order to reduce the amount of virus in their blood and to live a long and healthy life will also have the benefit of not passing the infection along to their partner as long as their viral load is suppressed. This is also referred to as treatment as prevention. This is an extremely important method for controlling HIV in the community. We won't talk about it at length in this series, but there are other resources to explore the importance of treatment as prevention. For the purposes of today's presentation, we'll focus on the first method, PrEP, which again is taking medication prior to an exposure. We know that PrEP works to prevent HIV infections. The PROUD and IPERGAY study, as well as the Partners Demo study, have shown that PrEP can work in both heterosexual partnerships where one person is living with HIV and the other is HIV negative, and among gay and bisexual men who have multiple partners to substantially reduce the number of HIV infections that occur. Both PROUD and IPERGAY showed 86% reductions in the number of HIV infections compared with people who are not receiving PrEP. And the Partners Demo study showed an even more impressive result. Further, we know from other studies that people who are taking PrEP medication daily as directed may have even higher degrees of protection, and more than 95%. The available data regarding the effectiveness of PrEP led to an FDA approval of tenofovir M-tricytidine medication, which is marketed as Truvada, in 2012. The CDC has also endorsed PrEP as an effective method of preventing HIV infections and recommends its use for people who are at increased risk of HIV. The CDC clinical practice guidelines were updated in 2017 and are an excellent resource for clinicians and managers of practices who are thinking about implementing PrEP or who have clinical questions related to PrEP. This is available online and the link is at the bottom of the slide. These guidelines include the CDC's recommendations for who should be offered PrEP. And basically, it's anyone who's at substantial risk of HIV infection. This means PrEP may be discussed with anyone who has a partner who's living with HIV, whether this is a man who has sex with men, a heterosexual woman or man, or someone who injects drugs. Also consider PrEP for clients presenting with a recent bacterial STI, anyone who's reporting a high number of sex partners and a history of inconsistent or no condom use, and for people who engage in commercial sex work. Also, injection drug users who share injection equipment may be considered for PrEP. These are basic guidelines just to think about general categories of people for whom PrEP should be discussed and potentially offered. It doesn't mean that PrEP is going to be right for everyone who fits into one of these categories. In general, it's a good idea to discuss PrEP with anyone who could potentially be at risk. Not everyone's comfortable disclosing same-sex sexual behavior or number of partners, but may benefit from information about enhanced prevention techniques, including PrEP. Now, since PrEP is only for people who are HIV negative, consideration of PrEP always starts with an HIV screening. It's important to establish that HIV negative status immediately before starting PrEP. Remember that the window period for HIV screening with an antibody test is at least 3 weeks to detect HIV infection. For a NAT, a nucleic acid test, it's 7 to 28 days in order to detect an HIV infection. And anyone who meets criteria for PrEP is by definition at increased risk for HIV, so it's very important to establish whether they may potentially be in the window period prior to proceeding with PrEP prescription. So what type of HIV test is best? A rapid test, if you have one available in the office, can be extremely helpful immediately to determine whether to continue a conversation regarding PrEP or to refer for care if the test comes back positive. Antigen antibody combination tests, also called fourth generation tests, are helpful for detecting recent infection, and they should be done if available for PrEP candidates because they are better at detecting in the early infection stage, while the antibody alone tests may still be in the window period. Here's a slide that goes over some of the window periods for the various tests, and particularly focusing on the detection of acute HIV infection. We know that the HIV RNA is the first marker to appear. This is what's detected in the nucleic acid testing, or NATs. It could be as early as 1 week after infection, although we sometimes see the NAT be delayed up to 4 weeks after infection. On average, this will be positive by 2.5 weeks. The P24 antigen shortly thereafter becomes positive. This has a slightly longer window period than a nucleic acid or RNA test, but is substantially better than the third generation antibody tests shown in the red bar. You can also see at the top of the diagram that about 60% of people will describe clinical symptoms as they seroconvert or become HIV positive. These symptoms may consist of fever, rash, sore throat, swollen lymph nodes, headache, and gastrointestinal symptoms, and other symptoms that are nonspecific and can be referred to as flu-like. If anyone reports these symptoms in the last 2 months when you're evaluating them, it's important to think about whether this may have gone along with an exposure and it could have represented a potential seroconversion to HIV infection. In this case, you would want to do more careful laboratory testing to evaluate for early or acute HIV infection before proceeding with PrEP medication. This is because we know that people who are early in seroconversion are the ones who've had issues with developing resistance to PrEP medication when it started without recognizing that infection. PrEP medication is adequate for protection, but is not adequate for treatment, as treatment for HIV usually requires 3 medications. Regardless of the test type that is chosen, delivery of HIV results should always include discussion of the window period for the particular test and of plans to stay negative. PrEP is always part of a comprehensive HIV prevention package, including condoms, counseling, frequent STD testing and treatment, and frequent HIV testing. It's appropriate at this time to discuss what would be the appropriate interval for HIV and STD testing. If someone is planning to start PrEP, we usually proceed every 3 months with these services. If someone is educated regarding PrEP and decides not to initiate PrEP, a less frequent testing interval may be indicated, or quarterly testing may still be appropriate. An initial evaluation for PrEP includes a pregnancy test for women, a test for the creatinine, or the serum, in order to calculate creatinine clearance. Using the current medication approved for PrEP, Truvada, a baseline creatinine clearance of greater than 60 milligrams per deciliter is required. Hepatitis B serology is done at baseline in order to evaluate for active hepatitis B infection. This is because the medication for PrEP includes 2 medications that also treat hepatitis B, and it's important to recognize if hepatitis B is being treated in order that it may be monitored appropriately, and also to counsel patients not to stop the medication suddenly, as it can cause a rebound infection of hepatitis B. STD testing is always done at baseline, and this should include testing for gonorrhea and chlamydia at all appropriate sites. For men who have sex with men, this may include testing from the throat, as well as from an anal swab and from the urine for urethral testing. Also, syphilis testing should be done. A baseline HIV test, as I mentioned, usually this could be a fourth generation test. If a rapid test is used in the office, a laboratory-based test should also be sent. And as we discussed, it's important to evaluate for symptoms of acute HIV infection in the recent past. So what to prescribe for PrEP? As mentioned, tenofovir M-tricytidine, which is marketed as Truvada, is the only FDA-approved drug for PrEP right now. 1 tablet daily is the only approved dosing strategy from the CDC. There are other guidelines from the IAS USA group. Pre- and post-coital dosing is not currently recommended, and it's recommended to prescribe up to a 90-day supply of medication. What are the common side effects of PrEP? The most common is nausea or stomach upset. This is experienced by about 9% of patients, and importantly, usually does get better if PrEP taking is continued after the first few weeks. A smaller percentage will experience headaches, and less than 1% will experience declining kidney function. Nevertheless, we monitor all clients at baseline and regularly for creatinine clearance. Also, a decrease in bone mineral density may occur. There's no specific recommendation for supplementation or monitoring related to this, and usually is only relevant for individuals with other bone health issues or frailty. So how do we follow a patient on PrEP? We do quarterly check-ins for HIV testing, side effects, counseling, and renewal of the 90-day prescription. The creatinine should be checked at baseline and then at 3 months, and after that it can be checked every 6 months if it continues to be stable. STD testing should be performed every 3 to 6 months. In most cases, for people who have multiple partners, every 3-month testing is appropriate. Every 6-month testing may be considered for people who are in a mutually monogamous relationship with a person living with HIV infection and without a recent history of STDs. This slide summarizes the guidance for PrEP use. So, to be clinically eligible for PrEP, we must document a negative HIV test result, ensure that there are no signs or symptoms of acute HIV infection, that there's normal renal function with a creatinine clearance of greater than 60 and no contraindicated medications, and we should document the hepatitis B virus status and vaccination status, and of course vaccinate as appropriate. The prescription should be for 1 tablet daily of combination TDF-FTC, which is marketed as Truvada, and usually a 90-day supply is prescribed at each quarterly visit. Follow-up visits should occur every 3 months and would include an HIV test, medication adherence counseling, behavioral risk reduction support, side effect assessment, and STI symptom assessment. And then every 3 months and every 6 months thereafter, assess renal function and test for bacterial STIs as we discussed. For men who have sex with men, it's important to do oral and rectal STI testing. For heterosexual women, assessing pregnancy status or pregnancy intent. And for injection drug users, access to clean needles, syringes, and drug treatment services should also be provided. So what are the potential benefits for PrEP? Well, the first and most obvious is to prevent HIV transmission. But taking PrEP can also bring more attention to sexual health, can help people to be more proactive and to take control of their sexual health. It can help resolve the discordance dilemma or decrease the stress and anxiety in couples where one person is living with HIV and the other is HIV negative. It can provide an added level of security that can be appreciated and help decrease psychological stress and anxiety. So to incorporate PrEP into HIV testing sites, for all HIV screening sites, it's important to provide PrEP resources and information. So many people have not heard of PrEP, and some may want additional information to research it or consider it before proceeding. So there are many pamphlets and patient resources available, and I'll introduce some of these later in this presentation. It's great to provide an appropriate resource at an HIV screening visit. And whenever counseling someone about the potential for taking PrEP, or someone who's following and already taking PrEP, discussing how PrEP will fit into the routine can be very helpful. For people who are already taking vitamins or other medications, it may be easier to fit another pill into that routine. Thinking about time of day that's most routine or most has the same activities each day can also be helpful. Pill boxes and keychain pill holders can be helpful. And it's important to reinforce that there's no interaction with recreational drugs or alcohol. Many people will assume that there is and may avoid taking PrEP when they are drinking or using drugs. And in fact, these are one of the times when we most like people to maintain and be adherent to PrEP. It's important to ask supportive and open-ended questions about adherence in order to be able to address any potential problems that clients are having with adherence. So what are the resources needed to provide PrEP in your practice? So clinic personnel will need to be trained and know what PrEP is and how to direct questions to the appropriate individuals at your clinic who have the most expertise. You may consider videos or written materials to help with passing information to clients. And build relationships with pharmacists. Pharmacists can help enormously with the prior authorization process and with facilitating adherence to PrEP. So identifying a local pharmacist or pharmacists who you're able to work with and facilitate PrEP prescription filling and adherence can be very helpful. Having administrative staff in order to handle longitudinal follow-up and retention and PrEP is important in identifying who will handle phone calls and paperwork related to PrEP. And having a linkage to care plan in place for HIV reactive results is also important. This is one of the patient information flyers that's available through the CDC campaign listed at the bottom, the website available for download. And this flyer is also available in Spanish. It has basic information appropriate for clients who are contemplating PrEP. Many of the resources available online are directed at gay and bisexual men, but Project Inform also has a flyer and pamphlet that's available specifically for women and can be helpful for the particular questions that clients who are women may have regarding PrEP taking. There are many other resources available online, and I've listed just some of them here. You may want to browse some of these websites and see if there are resources that may be appropriate for your clinic population to have on hand if there are questions related to PrEP or to introduce the concept of PrEP during the HIV testing process. So as I mentioned, I believe that all clinics that are providing HIV testing should be able to disseminate some information about PrEP and to educate clients about PrEP. But there are other models for PrEP delivery as well. So you can provide PrEP in the same clinic where you are doing the HIV screening. This is really ideal in terms of maximizing the chance that someone will engage in care. You can also refer to another clinic for PrEP. It's important that providers consider providing PrEP. PrEP is a prevention intervention, and it's most appropriate for primary care, and clients like to receive from their primary care doctor in order to minimize the number of appointments that they need to go to and to strengthen the relationship that they already have with their provider. We also know that passive referral of PrEP candidates from HIV testing sites results in less than 1% uptake of PrEP Whereas when you provide PrEP at the same site where the screening is done, you get about 50 or 60% uptake. So you can have a much bigger impact by providing PrEP directly and on-site. PrEP care is also reimbursable, so using existing billing codes for counseling, testing, preventive care, and follow-up is recommended. There are no specific ICD-10 codes for PrEP, but there are several applicable codes that will be accepted by payers, and these are listed on the next slide. So here are some ICD-10 diagnoses codes that can be used for PrEP, involving exposure to HIV or other infections, or behavior that may place an individual at high risk for HIV. These can of course be used in combination with other appropriate visit codes depending on what services are performed. And CPT coding for PrEP visits follows the outpatient visit codes 99202 to 99205 for initial visit and 99211 to 99215 for follow-up visit, based on the key components that are performed. And recall that these codes can be adjusted based on the time spent with the patient, as long as you document counseling that takes more than 50% of the visit time specifically. So if you're not able to offer PrEP directly, it's important to refer to other PrEP clinics in the community. It's still important to introduce the concept of PrEP after an HIV screening and provide resource lists specific for your community. Most infectious disease specialists provide PrEP in their practices. So if you're in a private practice with a consulting relationship with an infectious disease practice, this may be a good resource for you. Some federally qualified health centers have PrEP programs, and all 67 county health departments in Florida have the ability to provide PrEP. If someone expresses an interest in PrEP during a visit, following up to establish that linkage occurred with a PrEP provider is important. And if a person's not interested but does have a qualifying risk, it would also be important to check back in at the next visit, as many people need a little bit longer to decide and may eventually decide to try PrEP medication. To review some of the concepts that we've discussed, we're going to present a case. Private practice physician is seeing a 20-year-old single male for his annual physical before his senior year in college. The patient, who is not an established patient, has had multiple sexual partners, both male and female. The physician appropriately performs an HIV rapid test. The rapid test result is returned and is negative. The patient is counseled regarding prevention strategies, including PrEP, and he is interested in pursuing this. Baseline labs for PrEP, including a lab-based HIV antigen antibody or fourth generation test, creatinine, urinalysis, hepatitis B and C serology, and STI screening are ordered. The patient returns for follow-up in 1 week. All labs are normal, and he elects to start Truvada daily PrEP medication. The physician writes a prescription for 30 days of Truvada with 2 refills and schedules a check-in visit in 4 weeks. So how will this physician continue to follow his patient? Quarterly check-ins for HIV screening, side effects, counseling, and a prescription, and a creatinine every 3 months and every 6 months if it's okay after 3 months. STD testing at least every 6 months and could be every 3 months depending on risk. And again, for pregnancy tests, for women we would do a pregnancy test and reassess pregnancy goals and plans at each visit. So in conclusion, I'd like to think about the HIV prevention continuum, in which a negative test is really just the start of the continuum. The next step is linkage to prevention services, including PrEP, and then retention in services, including ongoing support, outreach, and counseling, and adherence support for people who elect to take medication as part of their prevention plan. I've listed here some references and additional resources that may be useful as you think about how to incorporate PrEP into your practice or your HIV testing program. Thank you for your attention. This project was funded by the Florida Department of Health through the Expanded Testing Initiative and through the South Florida Southeast AETC program and UHealth, the University of Miami Miller School of Medicine.